The case will be presented by Dr. Akriti Sharma. She is third year PG from Sri Shankara Institute of Medical Science. Today our faculty are Dr. S. Balasur. He is Senior Consultant, HOD, Director from Kanchikama Koti, Child Trust Hospital, Chennai. And I welcome you, sir. And our second faculty and expert is Dr. G Malini, ma'am. She is ex-HOD and Director from Jawaharlal Nehru Hospital and Research Center. With this, I'd like to invite Dr. Akriti Sharma for her case presentation.
Good evening, sir. Good evening, ma'am.
Good evening, ma'am.
I'm presenting a case of my patient, Tinkle, 13-year-old female, resident of Baloda, Chhattisgarh, Hindu by religion, daughter of Dijendra Vishwakari. Informant is herself and mother, and history is reliable. Date of admission is 23rd April 2024, and date of examination is 23rd April 2024. She came with chief complaints of rashes for 2 months, joint pain for 2 months, painful oral ulcers for 2 months, and fever for 20 days. Patient was apparently go on.
Please go ahead.
Apparently all right 2 months back when she noticed multiple rashes which appeared first on scalp, then on face and behind the ear, and in next few days involved the forearms, feet, and above ankles. Appearance of rash was insidious in onset and progressive in nature. Rash was associated with itching. Rash does not involve palms and soles. Now rash has decreased and hyperpigmented scaly lesions present where rashes have healed. No rashes over genital areas. She was applying ointment given by local practitioner, details of which was not available. Patient tells about joint pain since 2 months, which was insidious in onset and gradually progressive in nature, involving multiple large and small joints. Sequence of joint involvement is not clear. She got relieved on medication by local practitioner and she was given painkillers. Rest of the treatment history is not available. There was no nighttime awakenings or poor sleep due to pain. Morning stiffness was not appreciated by the patient. Pain used to increase with activity and later she started having difficulty in walking and using toilet. She told about fatigue that limited her playtime with friends and absence from school. On admission, she came to visit on wheelchair. Patient also complains of multiple oral ulcer, which was painful since 2 months, involving buccal mucosa and palate. Ulcers were painful and later affected her mouth opening and her oral intake. Her mother tells about weight loss of 5 kgs in 2 months. There was no bleed from ulcers. Patient had fever on and off since 20 days, intermittent type, used to occur once in a day for 4 to 5 days in week. Fever was recorded once when visited a nearby clinic, got relieved on medication. Fever was not associated with chills and rigor, and 5 spikes of fever daily documented in hospital stay of 10 days before starting of the treatment, which used to be around 10 to 101 degree Fahrenheit. There was no history of cough and cold, diarrhea, pain abdomen or distension, earache, sore throat, no complaint of redness of eye, no complaint of headache or blurring of vision or altered sensorium, seizure were noticed or told by the patient. Any abnormal behavior, activity, or weakness of limbs was not noticed. No complaint of chest pain, breathing difficulty, or syncopal attack told by informant. There was no complaint of pain during urination, decreased urine, or red colored urine, or burning micturition, and no history of any drug intake for long time.
Let's stop here. Don't worry about the past history. Okay. Now, okay, you finished the past history. Okay, fine.
There is history of swelling over left neck 5 months back, which was painful and had pus discharge and got relieved on its own. She also tells about excessive hair fall 5 months back for 2 months from all over scalp. Hairs used to easily come out in hands, and while combing hair, due to which she shove her hair off. There is no history of blood transfusion in past and no history of contact with tuberculosis patient.
Okay, you complete the history. Very nice.
Yes.
The history is very comprehensive. Please go ahead. I allow you to continue.
Okay, sir. Personal history. She is in 7th grade and her performance in school is good. Recently has given exam of 7th grade. She attained her menarche at the age of 12 years, regular and normal flow, which stayed for 5 to 6 days. And she used to change 3 to 4 sanitary pads in a day. And there was no history of abnormal sleep pattern. Immunization history, she is immunized according to National Immunization Schedule. BCG scar present. And the last immunization was at 10 years of age of tetanus. Family history, there is no history of similar complaints in family, similar history in family, and no history of arthritis, malignancy, or sickling in family, and no history of early deaths in family. Dietary history, the required calorie is of 2000 and she used to take 1650 kilocalorie per day and the required protein was 40 gram and she took 42 gram of protein per day and she was not able to take orally when she developed ulcers. So this history is pre-ulcers dietary history and she used to take more of liquid diet during painful oral ulcers. And her mother tells that she has lost 5 kgs over 2 months. Socioeconomic history belongs to upper lower class according to modified Kuppu-Swamy scale. Summary.
You finished. You're doing a good job. Please go ahead. I'm not interrupting you because you're doing well.
Okay, sir. Thank you.
You summarize, then we'll dissect the history. Don't worry.
All right, sir. So a 13-year-old girl with multi-system involvement in the form of gradually progressive bilateral chronic arthritis in knee with rashes and non-healing painful ulcers and pyrexia of unknown origin with weight loss and with history of hair loss in past.
Okay, right. Very Akriti, first of all, I must compliment you. You have spent a lot of time and got the history. But I want you to go back to the first sentence in your history with the presenting complaints. We'll start discussing the history in detail. The next slide. Next slide.
Yes.
Yeah. There are actually 4 complaints. Okay. One is related to skin, one is related to joint, one is related to mucous membrane, another is a systemic complaint. But there is some other symptom which I would have put it probably on top of all this, or at least as a third symptom or fourth symptom. What is that? You should have put.
Weight loss.
Excellent, excellent. Why is that important? Why is weight loss important? What's the importance of weight loss? Why do you think that should be there in the chief complaint? See, you must remember, first of all, the presenting complaints need not be what the parents are saying. You can actually modify. If you get a good history, after all, they may not know what is important. But don't you think weight loss is an important symptom as a presenting complaint? Yes or no?
Yes, sir.
Yes, so you should have added that. That's my comment number 1. You should have added that. You should have added that. And the second one, if you go to the history of present illness, go to the next slide.
Yes,
yeah. What do you mean by she was apparently all right 2 months back? What does that term apparently all right mean?
Sir, she was going to school, eating well, and
she was going to school. Is there any other reason to say she was apparently all right 2 months back?
Sir, she didn't have any concern regarding her
concern. Okay, now it's always very important to start appropriately. In fact, I always tell my students, the WHO and the UNICEF defines what is good health of a child. It is not simply freedom from disease, it is also normal growth and development. Was she completely all right in terms of weight, height, everything 2 months back?
Yes, sir.
Yeah. So you could have started off the whole thing with a statement saying, this adolescent girl who was apparently well, was gaining weight and height normally, was going to school and performing well, started developing multiple rashes, indicating that the disease had its onset only recently. Don't you think
Yes.
that is better? That's a better way to put it?
Yes, sir.
Okay, that is one. Second, you have described the rashes. What type of rashes is this? When you say rash, to me, a rash can be a macule, a papule, pustule, vesicle, bulle, nodule, plaque, petechiae, purpura, ecchymosis, ulcer, anything.
Yes, sir.
What type of rash? You never describe.
Yes, sir. Sir, it was a maculopapular rash.
No. The rash, what type of rash? Is it macule, papule, vesicle, nodule, pustule, plaque? What is it?
The macule and
Macule.
yeah,
You could have said
macule.
that. Rashes, macular, itchy
And-
or not itchy?
Sir, itching.
Itchy. Okay.
Yeah.
And then you also towards the end mention probable photosensitivity, but here you didn't mention. How do you elicit history of photosensitivity?
Sir, the rashes were on the exposed part of the body,
One,
face.
any other way to elicit history of photosensitivity?
And then she used to, if someone says that she is having burning sensation while
Erythema. More important sign of photosensitivity is erythematous rash. Okay. Photosensitivity rash is usually not very much itchy. Okay. Erythema, severe erythema, burning sensation. Did she complain of any burning sensation or itching?
Sir, itchiness was there, but she couldn't appreciate the burning sensation.
Burning sensation on exposure to sunlight appearing in the exposed parts of the body would have given you a clue that it is photosensitivity. And this is macule. Okay. What is the distribution of the macule? You said palms and soles are not involved. Was it more in the trunk, more in the exposed portions? Where?
Sir, more on forearms and face.
It looks like more in the exposed portions. Am I right?
No, sir. Yes, sir.
Yeah. Okay. Next slide. Yeah. Yeah, the rashes decrease and scaly lesions. Okay. Why did you specifically ask for history of rashes over the genital region?
Sir, to rule out Behcet disease.
Rule out?
Behcet disease. Sir.
Okay, specifically, yes, very good. Genital lesions could give you a clue that it could be Behcet's. Okay. Go to the next slide. Yeah. Now, you are talking about joint pains.
Yes.
And then, in the conclusion, you said she has arthritis. On what basis you concluded that she has arthritis? And she has monoarthritis or quasi-articular arthritis or polyarticular arthritis?
Sir, she told me about 3 joints which were...
No. Wait. Dr. Akriti,
Yes,
please
sir.
don't mistake me. Don't think I'm like a lawyer, defense lawyer, destroying your evidence. No, it's not that way. You said, keep the slide on the, you concluded saying that she has polyarthritis.
Yes.
Now I'm asking you, with this sentence, how did you conclude that there is arthritis?
Sir, because she said she was having difficulty in walking in the last few days.
Anybody who has difficulty in walking, you call it as arthritis?
Swelling and decreased range of motion.
Nowhere you have mentioned anything about swelling. Where is it in this slide? Am I right? Please don't mistake me for finding out the small omissions in spite of a good history. See, you have only mentioned about pain. Nowhere have you mentioned anything about swelling. Is it important or not?
Yes, sir.
Yeah. Unless there is swelling, you cannot conclude there is arthritis. You can only say arthralgia if there is pain. Swelling, tenderness, erythema, warmth. You should have inquired into. Was it there or not in this girl?
It was there.
Yeah, you could have added that. Could have added that. Then you have mentioned multiple large and small joints. That sentence to me is confusing. Multiple means how many? 2, 3, 4, 5, 6, 7, 8. How many? Which are the joints?
Yes, sir.
Why is that important?
Sir, to categorize it into posse, articular, and
No, you want to know whether it is involvement of the small joints or major joints or both symmetrically. And here, here again, you should have mentioned whether there was symmetrical involvement or whether there is any asymmetry with lower limb being more involved than upper limb being more involved than small joints more involved than lower limbs. I mean, upper limbs like that could have got the history.
Yes, sir.
Which are the joints which are ultimately affected in her?
Sir, knee joint more than.
Which are the first joint to get involved?
Sir, knee joint.
Both sides or one side?
Bilaterally, sir.
Bilateral. Then what happened?
Then, sir, simultaneously only at
Which
the
are
same.
the other large joints which got involved? Which are the small joints which got involved? To me, that's very, very important.
Elbow joints and interphalangeal joints.
What about metacarpophalangeal joints and intraphalangeal joints and metatarsal joints?
So interphalangeal and metacarpal joint were.
Okay. Why is that important? Why is that important? Normally, you must remember, except in psoriasis, distal intraphalangeal joint. In fact, when you have said rashes, you should have specifically mentioned involvement of the distal interphalangeal joints, which is very, very characteristically seen in psoriasis. I don't know. I'm still not sure whether this is psoriasis, but you did not give me a history that there were plaques. Okay, because psoriasis will be very itchy and severe plaques and photosensitivity may also be there, right? And distribution may be in the exposed parts, sometimes in the neck and trunk also, right? Involvement of the distal IP joints is very, very characteristic of psoriatic arthropathy.
Yes, sir.
Okay.
Yes.
Next is, was there any deformity which developed over the last 2 months in this child? I didn't hear you say.
No, sir. No deformity was there.
No deformity. Any swelling or tenderness?
So swelling was there, but she did not complain of it. But there was.
Yeah, you could have, mother would have asked, you could have asked and got the history that there is swelling. But that would give you a clue that it is arthritis. Okay, again, warmth and redness also you could have elicited. Right? Next slide. Morning stiffness is not appreciated. And you have put that it used to increase with the activity and later she started difficulty in walking. Okay, there are 2 children with arthritis.
Yes, sir.
Okay, both have pain in the morning. One child over a period of 3 to 4 hours starts improving. The other child worsens. What is the difference between the two?
Yes, sir.
What's your inference?
Child with osteoarthritis, sir, will improve with activity.
Any child with degenerative arthropathy, for example, an elderly man like me, okay, if I have arthritis over a period of time, the pain comes down after activity, it may indicate it may be a degenerative arthritis. On the other hand, if my pain and swelling become more following exercise, it may mean an inflammatory arthritis.
Inflammatory. Yes,
Follow
sir.
what I'm saying?
Yes, sir.
Okay. Okay. She told about fatigue, that okay, fatigue is a history that you got. And ultimately, at the time of arrival in the hospital, which are the joints which are affected?
Sir, elbow joint, knee joints, interphalangeal joints, and metacarpophalangeal joints.
What about ankle and metatarsal?
Sir,
You have put, she has come in a wheelchair, hip, spine.
no, sir, she did not complain of back pain or
Any involvement of the jaw, any involvement of the spine?
no, sir.
No. Okay. Go ahead. Next slide. So you are now concluding that she could be having a polyarthritis. Am I right?
Yes, sir.
Polyarthritis. And you are not sure, and which is involving the major as well as small joints, but not the distal IP joints. Am I right?
Yes, sir.
And not the trunk, spine, and spine or the jaw. Am I right?
Yes, sir.
Okay, go ahead. You have talked about oral ulcers. No, wait. Oral ulcers. Now, okay, oral ulcers. See, you put, what is it? You have not described the ulcer from the history. What are the color? Is it important?
Sir.
Hello?
Yes, sir.
Yeah.
Yes, sir, it is important. I have described it in examination, sir.
No. From the history, you could have got, see, an ulcer which is white, an ulcer which is the red. What is the difference?
The red color ulcer is aphthous.
Aphthous ulcer. What about white plaque-like ulcers?
Sir,
Candidiasis.
yes, sir.
So that's important. You could have described that. Okay. Very
Yes.
good that you gave a history of weight loss of 5 kg in 2 months. Oh, go to the next slide. Yeah. One thing I wanted to ask you.
Yes, sir.
In this weather, April, with the temperature of low, which is 100, 101, do you expect chill or rigor?
Yes, sir.
Very rare. Okay, fine. Okay, intermittent fever, 20 days. Right. Now, one other history you should have got about the fever and rash. What history was missing from you?
Yes, sir. Which came first?
No, some other history I would have got. Anybody can put in the chat box? Anybody can put the correct answer in the chat box? Okay, now I'll give you a clue. Suppose the mother says, sir, my child's rash appeared only when the fever came. When at the height of fever, the rash came, and the moment fever came down, the rash disappeared. Is that an important clue to you? No. Pavitra has put measles. No. Anybody? Which rheumatological disorder you characteristically get a rash at the height of fever, which disappears once the fever comes down? Any PG can put in the chat box. Excellent. JAA. Somebody has put. Okay, even rash. The rash in SOJAA, systemic onset juvenile idiopathic arthritis, will characteristically occur at the height of fever. And the moment the fever, in fact, young doctors will miss it also. Only nurses will make out when they are called for high fever. The rash will be there. The moment the fever crashes, the rash will have gone. That's very typical of a SOJIA. Okay. That history you should have got. Please go to the next slide. Yeah. Now, negative history. Why did you ask the history of cough and cold, diarrhea, pain, abdomen, distension, earache, sore throat? What is the importance of each of these symptoms?
Sir, to rule out the cause, any focal cause of fever.
Focal cause of fever. Do you think any cough and cold will be there for a child who has got an illness, arthritis for 2 months? No, unlikely. Diarrhea, pain, abdomen.
Sir, for ruling out inflammatory bowel
disease. Okay, aphthous ulcer, fair enough. Earache, sore throat for what?
Sir,
Earache, I don't know why you
for
asked.
rheumatic.
Sore throat for rheumatic, okay. Redness of eyes for what?
Sir, Kawasaki disease and
Kawasaki, does it present with 2 months of rashes, arthritis, and then fever?
no, sir.
Not at all. Redness of eyes would have given you a clue for some other disease. What is that? Uveitis, as part of any rheumatological disorder. Uveitis. Okay. Right. Headache or blurring of vision, altered sensorium seizures for what?
Sir, headache for hypertension.
Hypertension. Abnormal behavior, activity, weakness of limbs.
Neurological
Chest pain, breathing difficulty, or syncope.
Yes, sir. For cardiovascular complication.
Okay. What about pain during micturition?
Sir, a renal manifestation of.
Do you get pain due to nephritis in any collagen vascular disease? Is it painful or painless? No, if at all you think of painful micturition, only retest syndrome. Okay. Decrease urine, red color urine, burning. Okay. Go to the next slide. Drug intake. Which drugs did you ask specifically?
Sir, ATT and
excellent. ATT, alpha methyl dopa. Okay.
and
right?
yes,
Okay.
anti-epileptic.
Okay. Next. Yeah. Past history. There is history of swelling or that's a very interesting history. What do you get out of this history? Swelling over the left neck, had pus discharge and got relieved on its own. What is this? Which portion of the neck? Upper, middle, lower, anterior, posterior cervical, which area?
Sir, anterior upper cervical area.
What is this?
Sir, lymphadenitis.
Lymphadenitis. Pus discharge, 13-year-old. How common you get is suppurative adenitis and getting relieved on its own? I don't know. I'm not able to assess. Was it painful?
Yes, sir.
Is it associated with fever?
No, sir.
Did the child receive antibiotics?
Sir, she was not sure of the medication she took.
Okay, right, fine. Okay. Excessive hair loss 5 months back. Okay. Hair used to come. There is no any scalp lesions?
No, sir.
Itchy lesions? No. No history of blood transfusion. Why did you ask for history of blood transfusion?
Sir, for sickling, history of sickling in past, and also
You are suspecting
hepatitis.
Are you suspecting sickle cell anemia in this child who's 13 years old, who's gone around normally so far? I don't think it is relevant. No history of contact with TB. Okay, well, fair enough. Next slide. Personal history, school performance, okay. Abnormal sleep pattern is not there. She's menstruating fairly, okay. Immunization, okay. Next slide. Family history, okay. Right, fine. Next slide. Intake is fairly okay. Okay, fine, good. Next. Okay. Very importantly, what are the drugs that this child has received after the onset for 2 months?
Yes, sir. Sir, she used to take painkillers, sir. And
which painkiller?
Sir, she did not tell me about the painkiller.
Okay, I have no idea. Has she received any steroids?
Sir.
Antibiotic history?
No, sir, she did not take any antibiotic.
Okay.
And she apply some ointment.
Okay. Very good. Yeah, now I think Dr. Malini, you can take over and interrogate her on the summary. Then I'll come in. Dr. Malini, please.
So she is form of gradually progressive bilateral chronic arthritis in the knee with rashes. So far you have been telling polyarthralgia, now you have come back to only knees. Non-healing painful mouth ulcers and fever with weight loss with history of hair loss in the past. There is no lesions in the scalp.
Sir, ma'am, there was rashes over scalp. Maculopapular rash.
And at present, she has only bilateral knee arthritis. And the other
Yes.
joints are normal.
No, ma'am. She complained of joint pain, knee joint pain, elbow joint, interphalangeal joint, and metacarpophalangeal joints.
So you have vomited it out over here.
Okay, what is your conclusion? What is your conclusion? What are the possible diagnostic possibilities at the end of this long history?
Sir, this is a chronic disorder which involves.
Excellent. Good, very good. I'm happy that you're approaching in a very simple way. One, it's a chronic problem because it is there for nearly 2 months. Good. One, two.
And then, sir,
You
it
put
involves.
multi-system. You put multi-system. Which are the systems which are involved?
Sir, musculoskeletal system
Hmm.
and sir, GIT.
Pardon?
GIT, why?
GI. What is the history suggestive of GI involvement? How's her appetite?
Sir, appetite was good, but she wasn't able to have.
Did you mention anything about jaundice in the last 2 months?
No, sir.
Very important. Okay. Right? Okay.
Yes, sir.
GI, I don't know. I don't know what history is there to suggest GI involvement. You didn't give us any clue. Any other, which are the other systems which are involved in this side?
So,
Yeah. Fever due to involve which disease in which? Pardon? Okay, what is the cause for her weight loss?
Sir, due
Because her
to
calorie intake is fairly good.
sir, due to oral ulcer, she was not able to take anything since
Okay.
last 6 months.
Did you ask about polyuria, polydipsia?
Yes, sir.
No. Did you ask or not?
Yes, sir.
It is not there, no? Micturition
No.
is completely
No.
normal.
No, sir.
Okay.
Yes, sir.
Right. Do you think she has renal involvement?
So she did not complain of any thing which would suggest any renal.
No. What history would suggest that there is renal involvement?
Sir, decreased urine output or red color urine.
Okay. Suppose she says that the mother says, doctor, 2 months before and all, she used to pass urine only 4 or 5 times per day. Now she is passing urine 30 times a day. What does that tell you?
Sir, some renal disorder and polyuric phase.
Chronic renal tubular dysfunction, chronic renal failure also. Okay. Doesn't seem to be there. Neurologically, nothing seems to be happening. Hematologically, is there anything happening?
She was complaining of fatigue and weakness.
Fatigue is due to what? What are the conditions in which you get fatigue as an important complaint? Fatigue as a symptom. Said to tomorrow in your OPD, an adolescent girl comes to you saying, sir, I have lot of fatigue over the last few weeks or months. Please tell me.
Sir,
What are the
anemia.
conditions in which you get fatigue?
Anemia, sir.
Anemia, okay. Other than anemia, fatigue, easy fatigability. See, whole lot of conditions can cause easy fatigability. Just to give you an example, any chronic disease can cause easy fatigability, starting from chronic cardiac failure, chronic respiratory illness, right? Chronic anemia, chronic cyanotic heart disease, chronic acyanotic heart disease, chronic viral illness like HIV, EBV, right? Any chronic illness, psychiatric problems, adolescent with psychiatric problems, they may complain of fatigability, right? Any chronic illness. So what do you think this girl is having?
Sir, anemia, maybe.
Okay, no, with all
Chronic.
this, what is the diagnostic possibility?
Sir, according to history, this is a chronic disease, rash and joint pain, and with oral ulcers. So, suggestive more of some connective tissue disorder, SLE, or sir, systemic onset JIA.
Okay.
Yes, sir.
2, 3, 3.
Next.
Sir,
Any other possibility?
rheumatic fever.
Rheumatic fever, do you get oral ulcers like
No,
this, rheumatic fever with rashes like this going on for 2 months? What type of rash you get in rheumatic fever?
Sir, erythema margin.
That doesn't occur in the face and all that. No.
Sir.
Any
Sir.
other? You said first, you said SLE, second you said rheumatoid arthritis. So JA, okay, agreed. Third.
Sir, Behcet disease.
Behcet's disease, agreed. Rashes with fever, illness, oral ulcers, agreed. 4.
Sir, juvenile dermatomyositis.
Juvenile dermatomyositis, agreed. Juvenile dermatomyositis. Though you don't get this sort of arthritis, you get more of myositis, isn't it?
Yes.
Right. Okay, next. And proximal muscle weakness would be there much more than pain. Then?
Sir, Lyme's disease.
Lyme disease, will it cause rash for 2 months followed by fever?
No, sir.
Anything else?
Sir, malignancy.
Yeah, malignancy. Lymphoreticular malignancy can present like this with rash. A lymphoma or a leukemia can cheat us, presenting like this. And last but not the least, immunodeficiency. HIV can present like this. HIV.
Yes, sir.
Or any child with chronic granulomatous disease with some unusual infection can present like this. Okay. You must remember that this child has probably aphthous ulcer. The moment you get aphthous ulcer, the diagnostic possibilities that you have to think of are 1, cyclic neutropenia, primary immunodeficiency or secondary immunodeficiency. 3, periodic fever aphthous from PFA-PA syndrome. Have you heard of it?
Yes, sir.
What is the other name?
Sir.
PFA-PA syndrome.
Yes, sir.
Okay. Then you can get it in dermatitis herpetiformis.
Yes, sir.
You can get in Crohn's disease, inflammatory bowel disease, HIV infection. Any immunodeficiency can cause aphthous ulcer. Can run in families. Behcet's disease can cause aphthous ulcer. So a whole lot of differential diagnosis arises when you have recurrent aphthous ulcer. But in an adolescent girl, 13 years, this sort of joint involvement, ulcers, fever, weight loss, photosensitivity, in all probability, she has systemic lupus erythematosus.
Yes.
Okay? Right. Dr. Malini, you want to ask any more questions in history or shall we proceed for physical examination?
We can proceed.
Okay, please go ahead.
The general examination. Patient was sitting comfortably on chair, was conscious and oriented. To time, place, and person. She was alert and interested in surroundings. Temperature was 98.2 degrees.
Wait, Dr. Akriti.
Yes, sir.
Pediatrics is all about diagnosis at first sight. You know, the moment you see the patient, you must describe. You have a picture of this patient?
Yes, sir.
No. The moment you go near a patient, you have to ask, what is striking? Is this girl, adolescent girl, is she comfortable? One, you have put. Is she well looking or ill looking?
Sir, well looking.
Well looking. Is she well nourished or ill nourished?
Sir, ill nourished.
Ill nourished. Why did you say that? She looks well, she's comfortable, but she appears underweight.
Yes, sir.
Does she have obvious signs of wasting?
No, sir. But she
No.
was.
You go ahead. You go ahead. Go ahead. So always start with what you see on your first visual look at the child. Okay,
Yes.
go ahead.
Temperature was 98.2 degree Fahrenheit, taken in right axilla in sitting position. And the pulse was 92 beats per minute, regular, rhythmic, normovolumic, normal character. There was no radiofemoral delay. Blood pressure was 106/64 mmHg, which lied between 50th to 70th centile in right arm in supine position. Head to toe examination. Her hair was short as she showed her hair off, and it was sparse. Hair was lustrous and shiny. There were multiple maculopapular rashes all over scalp, face, forearm, legs. Some hyperpigmented areas present where rashes have healed. No rash over palms and soles, and rashes does not blanches on applying pressure, and rashes were not painful. Skin is dry and scaly, and there were no other cutaneous marker over skin. Eyes are normal and conjunctiva normal. On fundus examination, fundus was normal. Oral ulcers were present over buccal mucosa and hard palate, and there were multiple painful ulcer, whitish in color, irregular margins, and nails were normal.
Are they looking like aptoid ulcers?
No, sir.
No, they look like only aptoid ulcers to me from here, from whatever you're showing. Multiple ulcers. You need not have a typical punctate ulcer. Okay. Yeah, it's a little bigger than an abscess ulcer. That's what I can make out. Okay, fine. Go ahead.
Pedal edema was present.
Only thing is, the abscess ulcers are usually found in the lower lip or below the upper lip, not in the sides extensively like in this child. It is seen very extensively. Was there anything there on the soft palate?
No, sir.
Okay. Usually, in SLE, majority have ulcers in the soft palate. Right.
There was pedal edema.
Yes, ma'am.
Okay.
Pedal edema, you didn't elicit that in the history. Okay, it's okay, fine. Bilateral?
Pitting
Oh.
pedal.
Okay.
Tannis staging stage 4, anthropometry, weight was 35 kgs, lies between 10th to 25th centile against the expected of 44 kgs. Height is 141 centimeter. Mid-parental height is 149 plus minus 8 centimeter. And BMI is 17.6, which lies between 25th to 250th centile.
What is your interpretation of her anthropometry? Is there a problem with her growth?
Sir, no, sir.
No, she looks okay, fine. She looks well preserved. Okay, go ahead.
Systemic examination. So first I would like to go with musculoskeletal examination. I would like to assess the P gas at first go.
What is the expansion for P gals?
Yes, sir.
What is the
Expansion for P
expansion
gals.
for P gals? What is the expansion of the term P gals? Akriti?
Yes, sir.
Anybody? Yeah, somebody has put in the chat box. Pediatric gait, arm, leg, spine assessment.
Yes, sir.
Okay. It's a rapid 2-minute assessment
Yes, sir.
where is used as a screening test for musculoskeletal disorders and our children with arthritis. Go ahead.
Yes, sir.
Please go
I
ahead.
asked her 3 questions. That if she has any pain in joint, muscle, or back, and she said yes. Then I asked her if she has any difficulty while dressing herself up without any help or lifting any object above shoulder. She said no. And then I asked the third question that if she has any problem going upstairs or downstairs, or if she has any problem while squatting. She said yes. Then on performing the maneuvers, I observed her in standing position. The posture was erect. There were rashes over scalp, face, forearm, feet, and above ankle. Swelling was present over knee joint. There was
Both sides are one side.
So both sides.
Okay.
Yes, sir. Swelling was present over bilateral knee joints. There was no leg length inequality, no scoliosis or kyphosis. Spine was normal, no muscle wasting, and there was no flat feet. And then I asked her to pinch her index finger and thumb together, and I could see a good coordination among the small joints of fingers. And then I asked her to touch the tips of her finger, and there was good coordination among small joints of finger. And then I asked her to put hands together, palm to palm and back to back, and she could do that. So the extension and flexion of knee wrist joint was normal, and the flexion of elbow joint was normal. Then I asked her to reach up, touch the sky, look at the ceiling. She could do that properly. So the extension of neck, elbow, and wrist joint was normal, and shoulder abduction was also normal. Then I asked her to put her hands behind her back, and she could do that properly. So the shoulder abduction, external rotation was normal, and elbow flexion was normal. I asked her to bend forward and touch the toes, and she couldn't do that properly as it was painful. I asked her to open her mouth to put 3 fingers. She couldn't do that due to painful oral ulcers.
Why do you do that? Why do you do this?
Sir, to check the temporo
Very good. Go ahead.
And then I asked her to touch shoulders with ear, and she was able to do that. So the lateral flexion of cervical spine was normal. On patellar tapping, I couldn't feel any effusion, and there was pain during active movement of knee joint. And while doing the passive movement, I couldn't feel any crepitus. So then knee joint.
What is your assessment at the end of your PGALS examination in this child?
Sir,
did you find everything to be normal, or you found abnormalities?
Yes, sir. Sir, there was a difficulty while touching the toes, and the upper limbs, all the joints of upper limbs seemed to be normal. There were no pain. And while I asked her to touch the toes, there was pain.
Okay.
There's pain in knee joint.
Jaw was okay. Spine, was it okay?
Yes, sir. Spine was okay.
Okay, upper limbs okay. What about lower limbs?
Sir, there was pain during the knee joint movement.
Which are the joints which seem to be affected?
Sir, knee joint and hip joint.
Hip joint. Okay. Hip joint. Did you do the rotation?
Yes, sir. Sir, it was painful.
Painful. Okay, go ahead. Both sides, isn't it?
Yes, sir, both sides.
Okay. Ankles are okay?
Yes, sir.
There was no pain, tenderness?
No, sir. No, sir.
Okay. Small joints of the hands and feet were okay?
Yes, sir. Knee joint.
Okay, go ahead.
Knee joint examination. On inspection, there was swelling over bilateral knee joints. No scar mark, no incision mark. And there was a discoloration present. There was no deformity. On palpation, the femoral and popliteal.
No. Was there effusion in the knee or not?
No, sir.
No. That you should mention. You didn't mention in the examination of the knees whether there was effusion or not.
Yes, sir.
You just put crepitus. Okay.
Sir. Fetal tubercle was non-tender and tenderness over swelling of knee joint was there.
Go ahead.
No crepitus was felt on passive flexion of knee joint. There was pain during extension and flexion of knee joint, but was able to do it. There were no contracture, and on patellar tap, there was no effusion.
Okay, go ahead.
Per abdomen examination on inspection.
Anything you found abnormal in the abdomen?
Yes, sir. Hepatomegaly 3 centimeter is there.
Okay.
And rest of the system were normal, sir.
What did you look for in the cardiovascular and the respiratory system?
Sir, I looked for any murmur if present in
Cardiac failure, gallop, effusion,
pericardial effusion.
The respiratory, of course, crackles indicating cardiac failure or evidence of pleural effusion. Go ahead.
Yes, sir.
CNS.
Sir.
Will you examine the cardiac central nervous system?
Yes, sir. So there were no.
What did you specifically look for? One finding I would have specifically looked for. What is that? That too, when you're thinking of SLE.
Yes, sir. So weak.
Try to look for a tremor. Tremor, very frequent. Very frequent. Tremor. Okay. On a similar note, psychiatric disturbances, subtle disturbances might be there in adolescents with lupus. So you have to assess the higher mental functions and question about delusions and hallucinations also. Right?
Yes,
go ahead. Dr. Malini, you can discuss the findings before we move on to further discussion. Dr. Malini, please.
Yes. So far, she has been only the P-Gals. There are some findings for her. Abdomen, there was no pain, no tenderness.
No, ma'am.
Nothing.
No, ma'am.
No problem. Okay. And lungs.
Ma'am, it was normal.
What would you look for?
Ma'am, any added sound crackles, pleural fusion, basically, for findings for pleural fusion.
Pleuritis is more common in SLE.
Yes,
so
ma'am.
for a pleural rub. Okay.
Yes,
and go to the previous slide. There was no spleen, no splenomegaly.
No splenomegaly.
No splenomegaly. Okay. It's very common in SLE.
Yes, ma'am.
Splenomegaly is very common, and also in all even GI. Okay.
Yes, ma'am.
But the liver tender or not non-tender, is it?
Non-tender, sir.
Okay.
Yes,
Right. Madam,
Okay.
anything you want to ask in the physical finding before we go on to the discussion?
Let's go on to the discussion.
Yeah. What do you think is the most probable diagnosis, Dr. Akriti? Sum up the entire case and tell us what is the most likely diagnosis that you're thinking of in this adolescent. Don't do investigations now.
yes, sir.
I don't want to see the investigation. Don't worry.
Yes, sir.
For summary of history and physical findings and most probable clinical diagnosis.
Yes, sir. So, sir, the patient is a female of adolescent age and comes with a chronic complaint which involved multi-system. So, which probably suggest connective tissue disorder. Suggestive of mostly SLE or
before that, would you like to call this girl as adolescent girl as having PUO or not?
Yes, sir.
What is the definition of PUO or FUO?
Sir, 3 weeks of fever without any cause outside before investigation, and inpatient 1 week, more than 1 week of fever without.
Okay. Okay. Is this PUO or not?
Sir, yes, sir.
Yes. Now, if this is PUO, what are the categories in terms of etiology for pediatric PUO? Broad categories into which you classify the etiology of PUO. Yes, please. Can anybody put in the chat box what are the major categories? There are only 4 categories of PUO etiology. One is infection. Second is malignancy. Third is inflammatory causes or collagen vascular disorders or vasculitis. Fourth is miscellaneous. There are 4 groups. Okay. And which is the majority in these 4 groups in pediatrics?
Sir, infections.
Infection. What is the difference in the etiology of pediatric PUO and compared to adult PUO?
Malignancy is more common.
More common. Okay. Most pediatric PUOs are only infections which have unusual manifestations. Okay. Second common group is inflammatory. Third group is malignancy. Fourth group is miscellaneous. Can you give some examples of miscellaneous causes of PUO not fitting into infection, malignancy, or autoimmune? Anybody can put in the chat box.
Sir, dehydration.
Dehydrated. Does it cause PUO, dehydration? Does dehydration cause PUO? No. Only acute fever. Okay, the fourth group is a miscellaneous group, which are neither due to infection nor due to malignancy. Important causes are your periodic fever syndromes. Okay, what are they called today? What are they called? Autoinflammatory disorders. The second, somebody has put in the chat box correctly, drug-induced. Third is environmental causes. Person living in Ramagundam, daily the fever can go up. Fourth is a person who has autonomic disturbance, familial dysautonomia, Mediterranean fevers, drug fevers. Okay. Sometimes you can have ectodermal dysplasias, Rayleigh syndrome. Okay, all these are serum sickness, etc. That is the fourth group. Which group do you think this girl fits into? Do you think she has infection? And if it is infection, what infection can present like this? With fever, rash, arthritis, going on for 2 months.
Epstein-Barr.
Epstein-Barr. No. Okay, I give a clue. They have a cow in the house.
Brucellosis, sir.
That's what I would have first thought of. In this adolescent girl who has got rash, who's got arthritis, and who's got fever, brucellosis is one treatable disorder which can exactly present like this. Only thing unusual that doesn't fit into brucellosis, the rash has been there for 2 months, the fever came late. Arthritis came late. Brucellosis. Lyme disease, brucellosis are distinct possibilities. Even tuberculosis, there is a syndrome called Ponson's disease, where there is a reactive arthritis which can occur secondary to tuberculosis. Okay, reactive arthritis secondary to disseminated or occult tuberculosis. It's called Ponson's disease. Right? That is a possibility. In the infection, again, HIV should be thought of in an adolescent girl. However uncommon it is. Of course, you had rightly put hepatitis B. Hepatitis B as a possibility, though jaundice is not there. But hepatitis B can present like vasculitis. C also. EBV, CME also. Okay, these are some of the possibilities. Right? Okay. Now, is there a possibility of this being a malignancy?
Sir, there is more of
weight loss is
joint.
there. Weight
Yes.
loss is there. Yes, very well possible. Some of these acute leukemias can present with skin rashes and
Yes.
fever and arthritis-like presentation. They may
Yes.
have pain rather than arthritis. But they don't have effusion like you have in this child. You said the joints are swollen. Okay? Lymphoma is a possibility. Right?
Yes.
Okay. Now, when it comes to inflammatory disorders, what are the inflammatory disorders you will think of? Yes, please. Now, why is this child having edema, man? How do you
Sir.
explain the presence of edema in this child?
Sir, it may be because of renal involvement or hypoproteinemia.
Hypoproteinemia. How does hypoproteinemia occur in this child? How can it occur?
Sir,
Renal hypoproteinemia will present only with minimal pedal edema. It can, not that it cannot. Again, renal involvement unlikely because oliguria is not there, hypertension is not there, hematuria is not there, facial puffiness is not there. Renal is unlikely. Hypoproteinemia. If it is hypoproteinemia,
yes.
how do you think this child can develop hypoproteinemia?
Sir, she was not oral intake was poor since 2.
One because of aphthous ulcers, their intake may be poor. 1, 2. Any other possibility?
Sir, she might be having proteinuria.
No, proteinuria. Okay, agreed. 2. Third possibility, however uncommon, is that you have to start thinking of a protein-losing enteropathy due to an inflammatory bowel disease.
Yes.
Remember, a protein-losing enteropathy may not have overt diarrhea, may only have edema, may only have ascites or abdominal edema, malabsorption. Okay, right? It need not have diarrhea. I have seen protein-losing enteropathy presenting without diarrhea. These stools will be bulky, that's all. Foul smelling. That is a possibility which can occur in an inflammatory bowel disease. Can occur even in SLE or immunodeficiency. Okay, right. Now, child who has, is this SOJA? What are the points for and against?
Sir, there is a rash, joint pain.
The rash is persisting. Rash is the first manifestation. Arthritis occurred later.
Yes.
Fever occurred later, which is very much against SOJA.
Yes, sir.
SOJA is notorious. We already discussed that. Is notorious for evanescent rash and rather than this type of rash.
Yes, sir.
Okay?
Yes.
Evanescent rash is not there. Right? Now, last possibility. Fever, rash, some arthritis, weight loss. Any other possibility? Reason entrant for DD for PUOs?
Sir, hepatomegaly.
With or without hepatomegaly, splenomegaly, but anemia is there, thrombocytopenia may be there.
Yes.
Not HUS. Hemophagocytosis.
Yes.
Whatever the etiology for the fever, hemophagocytosis can present like this. And also in rheumatoid arthritis, you can have macrophage activation syndrome, which can have all these features. Though the child will be more ill,
Or
there will be pancytopenia. Very ill. This child is not so. These are the possibilities. Dr. Malini, you want to ask her some more questions before you go into the investigation part?
No, you have completed everything. Let's
Okay.
go.
Okay. Akriti, how do
Yes.
you manage this child?
Sir,
So
firstly,
SLE is more likely, isn't it? Because adolescent, rash, arthritis, weight loss, hepatomegaly, edema, unless
Yes.
proven oral ulcers, fits into a probable diagnosis SLE. Now, how do you manage this child? How do you investigate this child? And what did you do for this child?
Sir, first I would like to go with basic investigation, complete blood count.
Please read out the reports you got at the admission.
Yes.
Or tell us orally.
Yes, sir. Sir, in CBC, hemoglobin was 7.8. And sir, there was no leukopenia, but there was lymphopenia.
TLC, what's the TLC?
What is the total count? What is the differential count?
Yes, sir. So total count was WBC count was 4,500, and so platelet was 2.38. Lymphocytes was 35%, and sir, ASR was high, but it was not very high. 51.
How much?
51.
51 is high only, not
Yes,
very high. What do you mean by very high? 51 is significantly high. Okay.
Yes, sir. So
Only
ferritin,
ESR might be high because of anemia per se. You must remember, in
Yes.
anemia, ESR may be high. In polycythemia, ESR may be low.
yes, sir.
For example, you do ESR in children with tetralogy of Fallot, ESR will be 3 or 4. Right, go ahead.
Okay.
Next.
Yes.
Ferritin, you did that?
Yes, sir. Ferritin was also
What made you do ferritin?
sir, acute phase reactant.
Okay. What is the upper limit above which you start thinking of HLH 1000? They say any ferritin above 1000, you start thinking of HLH. Any ferritin around 10,000, it occurs only in malignancy or in HLH. Hepatic malignancy is unusual in children. So anybody who has PUO, pancytopenia, ferritin comes in 10,000.
Yes, sir.
HLH is most likely. Anything above 1,000, you should view with suspicion. Go ahead.
Yes, sir.
Smear.
Yes, sir. Sir, normocytic hypertrophy.
Did you do C-reactive protein for this child?
Yes, sir. Sir, it was high, sir.
What is the C-reactive protein level? Why am I asking for C-reactive protein in this child? What is the reason I'm specifically asking for C-reactive protein in this child? Anybody can put in the chat box. What is the CRP value, ma? You have the value?
Yes, sir. So 2.6.
2.6. 2.6 is not high. Okay. That gives you a very, very important clue. In SLE, CRP may be negative in spite of a high ESR like 100 or 150.
Yes.
Okay. That is one. Second, even in SLE, CRP may go up in the presence of 1 infection, 2 serositis, 3 severe arthritis. Okay. Any effusion in the joint or in the pleura or in the pericardium or in the peritoneal cavity may push the CRP up. But in a classic case of CLE without infection, there is what is called a discordance between ESR and CRP. In fact, in this child, if you get an ESR of 50 and CRP negative or 2 like that, it is very characteristic of SLE. Very, very characteristic. The only other diseases where you can get this discordance are Kikuchi disease. Sometimes inflammatory bowel disease like Crohn's disease, when there is only ileal involvement, the same discordance between CRP and ESR might occur. Paradoxically, in fact, studies have shown that the CRP levels in SLE are usually very low, very characteristic of SLE. Okay. Please go ahead.
Yes, sir. So creatinine was on RFT, creatinine was high.
What is it? What is it?
Urine routine?
Yes, ma'am.
Ah.
On urine routine
routine?
examination. Protein,
Albumin 2
yes.
plus.
And sir,
RBC.
RBC.
Yeah, microscopy hematuria is there, proteinuria is there. Okay, fine. Indicating some renal involvement. What about renal function test?
So urea was 65 and creatinine was 1.73.
Sodium, potassium, bicarbonate, etc.
That is normal.
Okay. Okay. Fine. Go ahead. Good. What else did you do?
So vitamin D.
Why was vitamin D done?
Sir, because in SLE there is Sir, there is vitamin D deficiency.
There is no need to do vitamin D. You should do only alkaline phosphorus, calcium phosphorus. If without doing that, you should not be doing vitamin D, because vitamin D will be universally low in everybody. B12 also. It doesn't take away anywhere. It's a waste of money. Please go to the next slide. What other tests did you do?
Sir, we did ASO titer and
What is it? Why did you do ESO for this child?
sir, for rheumatic.
I don't think so. Right, fine. Okay,
Sir,
negative.
and then we did ANA titer, which is positive, and anti-double-stranded DNA.
dsDNA was positive?
Yes, sir.
Okay, right. What is the significance of ANA positivity when you ask for the test? Anybody can put in the chat box? What method you did for doing ANA?
So it is sensitive for SLE, but it might come positive in many other diseases, and also it can.
10% of population may have ANA positivity. Okay, you should not do ELISA to do SLE, the ANA testing. Okay, should
Yes,
not
sir.
do ELISA.
Immunofluorescence.
Okay, should do only immunofluorescent test for ANA, correct method, so that you get the correct value. 10% of population can be positive. Anti-dsDNA is highly specific. Of course, in this child with renal involvement, I would have done C3 and C4. Was it done?
So it was not done.
Okay.
But
it should be done. C3, C4 is indicated. The C3 will be invariably low. C4 also will be low in such children with SLE.
Yes, sir.
Okay. What
Yes.
other tests? I would have done liver function test because there is edema.
Yes, sir.
Hypoalbuminemia I will look for.
Yes,
Right?
sir. Yes, sir.
Okay. Then what else? What else would I have done? I would have done an ultrasound to look at the echogenicity of the renal parenchyma. Right? And I would also do an echo to find out if there is any pericardial effusion or myocardial dysfunction. And I will ask for a referral to ophthalmologist for uveitis.
Yes, sir.
Okay. Then, if the child is having fever like this, I would have definitely 20 days fever. I would have done even a blood count, blood culture.
Yes, sir. So
Culture, urine culture also.
There was no.
Any other slides you have?
No, sir.
Okay. This is the X-ray. X-ray. Please show me the X-ray. X-ray looks fairly okay. Right. Ultrasound, no finding. Echo is done.
Yes, it was normal.
Opthal.
Sir, it was also fundus was also normal.
Yeah, somebody has put, Dr. Kiran has put APLA. Why should you do APLA for this patient?
For clotting risk in this, and for APLA syndrome.
You need not do routinely. In fact, you're definitely going to put this adolescent girl on which drug? Hydroxychloroquine.
Yes.
Phospholipid antibody syndrome.
Yes.
There, hydroxychloroquine is definitely indicated in this child to prevent thrombosis.
Yes.
Okay. Now, does this girl, you can actually stop sharing this slide.
Yes, sir.
Yeah, Dr. Malini, madam, you can ask some questions before I ask her some more questions.
So if you are going to put her on hydroxychloroquine, how would you monitor this child?
Sir, ma'am, I would go for a fundal examination every 6 monthly to see the retinal deposition.
Just fundus,
Ma'am,
location, color vision,
yes, ma'am.
all
Yes,
that also has to be done.
yes.
Okay. And this child had a urine RBCs and proteinuria also, 2+ of protein. And
Yes.
creatinine was 1.7. Did
Yes.
you get the GFR?
Yes, ma'am. It was moderate to severe, and 30.6 EGFR was 30.6.
Per meter square, per 1.73 meters square.
Yes, ma'am.
Okay. So this child had a moderate renal involvement.
Yes, ma'am.
And how do you would you classify? Before starting treatment, whenever there is renal involvement, ideally it would be good to get a renal biopsy done and then start treatment for this patient. Okay. So, what are the other drugs which are used?
Yes, ma'am.
Hydroxychloroquine is a must. Then what are the other drugs which can be used?
Ma'am, corticosteroid and steroid sparing immunosuppressive agents like cyclophosphamide and mycophenolate mofetil, azathioprine rituximab, and
okay. Sir, आप कुछ पूछना चाहते हैं तो पूछिए.
Yeah. Two things. In this child, I would have done the following investigations. One is a 24-hour protein estimation. Second is serum cholesterol and albumin to find out if there is nephrotic syndrome. Because there is edema, there is significant proteinuria. So I would have looked at the possibility of nephrotic syndrome, nephritic nephrotic syndrome. Two, I would definitely do a biopsy for her to grade the renal disease. The reason being, if there is no renal, this child definitely has renal involvement. I don't think anybody will treat SLE of this severity without renal biopsy. Third, hydroxychloroquine is a must to prevent thrombosis. And it is a very, very safe drug. You can do 6-monthly slit clamp examination and fundus examination to look for the adverse effects of hydroxychloroquine, which are extremely rare. It's a very well tolerated drug. And for a patient like this who has classic SLE, if infection is ruled out, I will give pulse methylprednisolone, probably 30 mg per kg for 3 to 5 days to remit the disease, then followed up with the prednisolone in tapering doses, and then start tapering so that I reach the minimum dose required to control the disease. And in this child, only giving steroids is not enough. The ideal drug would be to start mycophenolate, and depending on renal biopsy findings, the grading of the disease is done. I'm not a nephrologist. Nephrologists would, of course, decide on starting either cyclophosphamide or rituximab, depending on the severity of disease. And of course, in such patients in whom you're going to give chronic immunosuppressive therapy, you would definitely do a TB quantiferon gold also. Manto may be useless. IGRA should be done to rule out underlying exposure to Mycobacterium tuberculosis. Periodic monitoring of renal function, good dietary practice, and provision of a sunscreen to her, explaining to her to avoid photosensitivity and sunlight exposure, and counseling in the family regarding the chronic nature of the disease. For this disease, amenable to treatment, but is notorious for all sorts of complications. Okay, right. Okay, madam, if anybody else, you have any comments, or if anybody else wants to comment, it's open for discussion before we take any questions from the chat box.
Exactly. I was also thinking of the special vaccines the child should receive.
Yeah, the vaccination. Yeah. Vaccination. She's an adolescent. I don't think I'll worry about vaccination now because she is ill. I'll give steroids. I'll think about vaccination only when she goes in for alternate day steroids.
Yes.
Okay, or very low dose steroids. No, I won't give her any live viral vaccine. Because
No live
I can give flu vaccine to her, but she is more prone for influenza than others. Okay.
Akriti, how about the prognosis for this child? Yeah, for SLE. For SLE.
Ma'am, 5-year survival, 80 to 90%. And 10 years of 80 to 95%, and 10-year survival is 80%.
I think it depends on the renal biopsy, ma'am.
Yes, it depends on the renal biopsy. And previously, it had a very bad prognosis. Now we have better drugs and better management of this patient.
She will certainly grow into adulthood and will be in the hands of an adult rheumatologist and nephrologist. Rather, she'll escape from us.
Yes.
Yeah. C3 we already mentioned, Kiran. We already mentioned C3 hypocomplementemia is frequent. C3 levels will be low in this child. Okay. Right. Of course, the other test you should have done is Coombs test. Anybody with the SLE, autoimmune hemolytic anemia can occur. Okay. It's an emergency. And Coombs test is very much indicated in such cases. Okay. If there are no other questions, I think I hand over back to Dr. Kishore.
Thank you, sir.
Kishore.
Thank you, sir. We are very fortunate to have our Dr. Kiran Makhija, sir, President CGAP. Sir, I welcome you, sir. And I like to invite you, sir, for your blessing and few words of blessing and, sir, appreciation, sir. Makhija, sir, please, sir.
Thank you, Kishore, and thank you very much, sir, Balasubramanian, sir, and Malini, madam, for the excellent, so much of the scientific as well as the knowledge for the case presentation. And we are very fortunate, sir, you are here with us for all the PG programs and all the examination purpose. So not only our PGs, but also the pediatricians who are joining and listening to you must be having great experience, sir. Thank you very much, sir. And thank you, DURG BHILAI Academy of Pediatrics, for inviting me here.
Thank you.
Thanks a lot, sir. Thank you, sir.
Thank you.
First of all, I'd like to congratulate Dr. Akriti Sharma for her nice presentation.
Yeah, she has done very well. She will get a distinction in the exam if she presents like this.
Thank you, our faculty, Dr. S. Balasubramanian and Malini, sir, for sparing your valuable time with us and enlightening us with your knowledge and thoughts, sir. And thank you all the viewers, seniors, all the respected seniors like Dr. Ashwini Agrawal sir has joined, Dr. M.S. Thakur sir, Motwani sir, Nutan sir, and all the seniors, colleague, and president. Thank you all for attending this webinar. And thank you, the Juventus group, Dr. Yogesh Joshi ji, and whole Juventus group for their support and providing us this beautiful platform for the presentation. Thank you. Thank you all. Good night all. Thank you, sir. Thank you again.